Thank you for joining us for today's webinar. You are in listen-only mode. We do have a Q&A box. You're welcome to ask questions within that box at any time, and we will hold questions towards the end after Dr. Blazinski's talk. I will now turn it over to Patrick McCartney, our moderator.
Great, thank you, Katie. Welcome everyone to today's webinar on the All of Us research program. My name is Patrick McCartney. I'm the Executive Director of the International Essential Tremor Foundation and a proud member of the American Brain Coalition. I'm also an ABC board member, and as Katie mentioned, I'm chair of the ABC's program committee. So today's webinar will provide you with an overview of the All of Us research program, which is a historic effort to gather data from 1 million or more people living in the United States to accelerate research and improve health. By taking into account individual differences in lifestyle, environment, and biology, researchers will uncover paths toward delivering precision medicine. So we're thrilled to have Dr. Catherine Blazinski, who is Policy Director for the All of Us research program, speak with us today. Dr. Blazinski is a neuroscientist and a geneticist specializing in research on mental health and cognition with a focus on health disparities. So as ABC's program committee chair, I reach out to ABC members asking for recommendations on webinars and meetings the ABC membership might like to hear more about. And I heard from a number of our members who attended the 2019 NINDS nonprofit forum how interesting it was to hear about the All of Us research program and how many of the members would benefit from learning a bit more about it. So as Katie mentioned, we will allow questions at the end of Dr. Blazinski's talk, so please feel free to ask them in our question box, which is located at the bottom of your screen at any time. So please join me in welcoming Dr. Blazinski.
Thank you so much for that, that wonderful warm welcome, and thank you all for coming today. I'm honored to be here to give a bit of insight into the challenges that have been faced by the All of Us research program, some of the challenges that we are continuing to face, and also some of the ways that we've gone about approaching those challenges. So next slide, please. So first, let's start with a little bit of an overview of All of Us. I think you heard the bulk of what I was going to disclose in this overview in my introduction. But let's proceed through that as well, maybe get a little bit deeper into that. So next slide, please. So all of this is part of the Precision Medicine Initiative, and we bandy about the phrase precision medicine a lot right now, but what we're talking about in this case is getting the right treatment to the right person at the right time. At present, precision medicine is still in its, I'd say, toddlerhood, or at best, its adolescence. We certainly have examples of precision medicine like eyeglasses that have been around for generations, but both the conditions for which precision medicine treatment is part of the current clinical practice and the proportion of patients for whom leveraging precision approaches is feasible is still extremely limited. Next slide, please. To expedite the arrival of this age of true precision medicine, the White House announced the Precision Medicine Initiative in 2015. And it was codified by the 21st Century Cures Act 1 year later. And through that codification, the All of Us research program was born. Next slide, please. So what actually is All of Us? It's not research per se, though research is in the name, but it's an assembly of a rich longitudinal resource of multimodal data on 1 million or more individuals living in the United States. Next slide, please. When we say multimodal, we're talking, at least at present, about a collection of participant surveys on such topics as family health history, environmental risk factors, and mental health, physical measurements like BMI and blood pressure, data from mobile and wearable devices like Fitbit, full electronic health record information, biospecimens, including DNA, and geospatial and environmental data that have been added from external sources. Next slide, please. The resource also aims to incorporate data from a diverse set of participants with efforts to over-recruit from populations that have been historically underrepresented in biomedical research. Next slide, please. And by diversity, we mean diversity along several axes, including demographic categories like race, ethnicity, age, gender, socioeconomic status, as well as health status and geography. Next slide. The resource also seeks to serve a diverse set of users, including both traditional academic researchers and citizen and community scientists. Next slide, please. The program operates according to a rather ambitious set of core values, I think. These values guide our operations and our implementation efforts. Next slide, please. I say ambitious because in order to adhere to these values, there's some important and rather challenging considerations that we must contend with. Next slide. So some is actually rather underemphasizing, I think, the myriad challenges that face a program, or any program actually of this scale. So in the interest of time, I'm going to touch on only a few that stem from a select set of our core values. Next slide, please. Beginning with the first two values here. And those are that participation is open to all, to basically everyone who wants to, and that our participant population will reflect the rich diversity of the United States. Next slide, please. Okay, so we are opening participation up to everyone. It's a nice idea, but if we want to do that, how do we do things like ensure that we have appropriate geographic and demographic reach? How do we truly ensure informed consent across literacy levels and across logistical needs? And how do we do our due diligence to enfranchise participation across sociocultural groups and communities? Next slide, please. We definitely don't have all the answers to these questions. For instance, right now, only individuals over the age of consent in their locality with the cognitive capacity to make an informed choice, who are not currently incarcerated and who speak either English or Spanish fluently, are eligible for the program. So right now, it's probably a safer statement that we're the Sum of Us research program, but we are working extremely hard to change that. And what we're doing is employing different strategies to engage with populations across the United States, the District of Columbia, and the 5 populated territories. The majority of our current participants, of which there are, I believe, around 300,000 to date, engage with the program through their hospital system or healthcare provider organization. So this is a high-touch method operating through what are largely seen as trusted intermediaries for those participants, which, sorry about that. So hopefully we won't get kicked off again. But we were talking a little bit about the various strategies that we're using to bring participants into the program from whatever location they find themselves in. So we've done this with about 300,000 people to date. And most of those people are coming through their healthcare system or their healthcare provider organization. And that is a very, very high touch method. So that operates through that trusted intermediary of the healthcare provider. But that's not the only way that people can come to the program. We also have a way that they can come to the program on their own, not supported by their healthcare provider organization. And this is called the direct volunteer pathway. So I believe we are now on slide number 16. If you can switch to that slide. The direct volunteer pathway becomes increasingly important for us to reach our goal of 1 million or more participants because, as you can see, our in-person enrollment capabilities are quite limited. At some point, the patient population of our healthcare provider organization awardees are going to be tapped out, and we need to ensure that there are other ways for people to reach and participate in the program. So furthermore, the sites are actually kind of geographically clustered as well. So there are entire states without a physical enrollment site. And if we want the cohort to reflect the true diversity of the United States, we need to provide mechanisms for people in all locations served by the program to sign up and to take part. And that's, again, where the direct volunteer path comes in handy. Next slide, please. However, serving the entire US, DC, and the 5 populated territories presents its own unique set of challenges. And this is an incomplete map here showing only states, unfortunately. I'm sorry, I was only able to find a state map in R. So these are states that have laws that in some way affect our consent process. So in total, we've had to craft 4 versions of our primary consent, at least 6 versions of our HIPAA authorization, and 2 versions of the consent for the return of genomic results, which is not to mention variations in such criteria as the age of consent that also impact the process of bringing people into the program. And those numbers change as state and territorial laws change. This is an ongoing challenge. Next slide, please. So to enhance the broad access to the program, we've adopted a readability limit for our program for all participant-facing materials, including the consent process. Everything reads at or below the 5th grade reading level, which means that about 80% of the US population is, in theory, able to understand those materials. Now, you might have wondered after the map slide why I mentioned that there are 3 components of consent. Next slide, please. That's because in an effort to make the informed consent process both more conceptually intuitive and manageable, we've adopted a modular multimodal consent with 3 components at the present time. Those are the primary consent for the core elements of the program, the HIPAA authorization for the release of electronic health records, and coming very soon, the consent for the return of individualized genomic results. We are starting with trace and ancestry, but the consent is for all of the results that we plan to return as a program, including health-related results and raw sequence data. Next slide, please. So a bit of a walkthrough of that consent process. It is heavily reliant on digital technologies. It's entirely digital. And again, to maximize the reach of the program to places where it's difficult to find a healthcare provider or another means of connecting with participants personally. Though, I will mention that reliance on digital paths to participation presents its own set of problems again. And those are problems that we are still currently wrestling with. But because we've gone digital, we can also employ a multimodal process of consent, consisting of a set of screens with limited text that will walk participants through important elements of the consent, videos that further emphasize content and that may reach participants who are less comfortable reading information, formative evaluations to help participants and also the program gauge whether participants have fully understood the conditions of participation, and also a traditional long-form consent at the end that ties all that information together in which the participant may sign. Next slide, please. So throughout that entire consent process, and in fact beyond, we have a support center that's open 15 hours a day, 7 days a week, importantly except holidays, to help answer participant questions and assist with technical problems. Next slide, please. I'm not sure if this is going to work for us, so it's probably safer to skip over it, but I have inserted one of our videos here, and in the version of the slide deck that's posted, I will put in the link to all of our consent videos, and you can watch them at your leisure. Next slide, please. So I believe we are on slide number 23. So great. Lots of people can, in theory, get signed up for the program, but importantly, how do we get the people we want to sign up? And here we have to acknowledge that for many of these groups and communities, we are up against a rather abominable history of marginalization and abuse by the scientific community. Next slide, please. Yet it's really super important that we do enfranchise these groups. There's overwhelming evidence here of the persistence of demographic bias in research. So this particular data on this slide comes from a survey of GWAS data, but next slide, please. It's very clear that this bias extends well beyond racial and ethnic minority status to include age, sex, gender, sexual orientation, income, geography, disability, et cetera, as well beyond GWAS. Next slide, please. Yet meaningful inclusivity is an absolute necessity for justice and for science. So we have a steep uphill climb to rebuild the trust with these groups and communities, as well as to create value that makes their participation worthwhile, and specifically worthwhile to them and or their community. Next slide, please. And rebuilding trust is no small endeavor. So we should be on slide number 27 here. We've begun the process by developing a network of healthcare provider organizations that we've mentioned earlier to act as those trusted intermediaries to a diverse set of patient populations. And the diversity of their patient populations was a criteria that we used in evaluating those awards. In addition, we've made it easier to participate, again, no matter where you are, through the direct volunteer pathway and organizations that can help to bring people into the program where they live. But also crucially, we've built a network of national and local community partners. And these are organizations serving particular underrepresented groups and communities that help to broker relationships with people and spearhead efforts to shape the program to meet a diverse set of needs. But perhaps most importantly in this process, we must listen. We must hear what these groups and communities are saying to us, and we must turn those recommendations and comments into action. So I think we've started down that path. We're making a good faith effort, but I think we as a program and also the scientific community in general still have a long way to go yet. Next slide, please. So let's move on to another set of considerations. And here let's focus for a moment on the All of Us core value, promising participants access to their information. Next slide, please. So clearly this is one of the primary sources of value that we can create within the program. People want this information. But, and next slide, it's really not always easy to just send them an email with some results. Results are often really confusing. Learning someone's results, that might cause them to have emotional, social, or even financial repercussions from learning those results. The promise to return information, including results, opens another can of worms, which includes, but is certainly not limited to questions like, how do we return that information in a way that conforms to our legal and regulatory requirements? For example, how do we negotiate between a somewhat parallel, not necessarily conflicting, requirements of, for example, common rule and the FDA, in the case of returning health-related genomic results, for example. So what information should be returned? Is there any information that shouldn't be returned? And how do we make those types of decisions? When we have a set of information that we want to return, when we've made those decisions, how do we make sure that we do it safely and at the scale of something like the All of Us research program? And finally, how much of these decisions is reasonable to leave to the participants? And when do the obligations decide rest with the program itself? Next slide, please. So it's not an easy set of questions, but let's focus for a moment on the balance between this sort of programmatic paternalism and this participant autonomy, because within that conundrum rests another set of, if you will, sub-conundrums, let's call them. Next slide. So at All of Us, we have a system of consent that, let's face it, is also a pretty good motto for life, which is that yes and only yes means yes, and everything else means no. It's almost wholly opt-in. So if we don't hear from a participant, if they don't agree to the consent for return of genomic results, for example, we are not going to annotate their sequence data and derive variant calls. If they don't sign the HIPAA authorization, we're not going to ask for their electronic health records. So the participant gets to choose that their own All of Us journey and navigate that journey on their terms. Next slide, please. And so furthermore, we've adopted a philosophy of fairly radical participant autonomy. So long as we do our due diligence to inform them of the relevant information, we feel that most decisions about what to disclose and when and to whom to disclose that information should be participant decisions. Among the data we make available, participants choose what to receive. They can select to receive some of that, all of that, or none of that. They can select that now and say no, and then change their mind later. Unless we're required to share the information by law, they also get to choose whether they want to give their information to anyone else, including their family members and their healthcare providers. What is our job is to make sure that we provide ample support for participants to facilitate educated decision-making. That means educational resources and support services that are available to anyone, regardless of where they are in their process. Ensure that the method of interacting with participants, particularly around results, is done in culturally competent ways that minimize predictable risk. Next slide. And we should be on slide number 34 now. So finally, let's shift our gaze to the research resources and the core values that promise both broadly accessible resources that simultaneously adhere to strict privacy and security standards. Next slide, please. So great. This is actually another extremely hard problem here, one that begets numerous questions of its own, including how do we create a system that actually does what we're promising? How do we appropriately obfuscate identities while preserving the scientific utility of the data? And critically, how do we remove barriers to the use of data resources while also preventing the misuse of that same data? Next slide, please. So in other words, how do we magically balance the priorities of access and oversight? And to do this, we must consider such questions as what are the risks of opening up access to these data? We're thinking here not only of risks to individual participants, but also to groups, to communities, to the research community, the government, and to society at large as well. Can we adopt some sort of framework here that maximizes utility while minimizing risk? So sort of the logistical approach. Can we adopt an enforceable code of conduct and set appropriate guidelines around user behaviors? And how do we as a program track the use of that resource in a way that achieves the necessary oversight without being over-restrictive or overbearing? So again, we do not have all the answers here. What we do have are some possible solutions. So next slide, please. So first and foremost, we are serious. We say we wanted to open the resources up past the community of academic researchers that traditionally access these kinds of resources. So that means we're talking classrooms that are learning about genomics and want to use some practical data resources. We're talking about community and citizen scientists who don't usually get the wealth of data that would be available through these resources. We're talking about traditional Black colleges who may not, again, have the resources themselves to set up research programs that would allow them to access this wealth of data. But we're also thinking of those traditional users, those academic researchers, as well as industry. Next slide, please. So to enhance the feasibility of that openness while retaining the ability to closely monitor the use, we've constructed a cloud-based platform through which all approved users will access and analyze the data. Users can upload certain types of data to this platform. They can remove certain types of analytical results, but they don't get copies of the data to analyze on their personal system. So that's divergence from the norm. All granular analyses that they're going to conduct happen through this cloud-based platform. Next slide, please. We've also tiered the data by level of sensitivity. So there's a public tier, which is actually already been released, and it's accessible to anyone and everyone. Data that's restricted, this data is restricted to low-risk aggregate data that's binned into buckets of 20 or more individuals, and 20 or more depending on the data type. In the registered tier, we get into the individual level data here. So again, that data are relatively low sensitivity, including some demographic data and standardized elements of the electronic health record. The control tier is also individual level data, but these data are more sensitive. So things like whole genome sequence data and narrative elements of the electronic health record will reside in that control tier. So regardless of where the data resides, however, steps have been taken to remove direct identifiers and alter the data to further complicate efforts to re-identify participants. Next slide. And here we should be on slide number 40. So in order to gain access to both the registered or the controlled level tier, users have to go through a process of approval, which will include ID verification, ethics training, and in some cases, institutional sign-off. We have yet to determine the full extent of the approval process, so stay tuned for that. We will be finalizing at least one of those shortly. However, once a user is granted access, what we have determined is that they'll get what's called a data passport. We won't be pre-approving their research proposals. If they have access, they can use the resource for whatever research project or project they choose, so long as it follows our rules. Next slide, please. Nevertheless, even with the data passport, they still need to tell us what they're doing with that data. That means that for each project they establish, they must write a comprehensive and clear project description, and this description will be publicly posted. The program will be auditing these descriptions and the workspaces that they are attached to ensure that everyone is following the rules, but anyone with access to the internet can read these descriptions and can flag a workspace for programmatic review. Next slide, please. Unfortunately, no matter what we do, no matter how careful we are, there is always a potential for misuse. Technology is moving at an immeasurable speed, so the potential for misuse continually grows. So how do we as a program, with those restrictions, go about minimizing misuse? How do we do things like establish the trustworthiness of our data, of our users, and obfuscate the data? But again, maintaining scientific utility. We need to create terms of use and monitoring for violation that are practical, but also stringent enough. And we need to figure out how to appropriately punish abusers of that access privilege. Next slide, please. So we talked a bit about the process of gaining access and a bit about ways we make it harder to misuse the data itself, but now let's talk a little bit about the rules that we require users to follow. So we have a data use agreement, and the requirements of that code of conduct within the data use agreement is not a small ask. So what we're asking people to follow is fairly serious. For example, we place the responsibility upon the user to follow all applicable laws, all of them, as well as regulations and policies. So within the contract, we provide them with resources for acquainting themselves with these laws, regulations, and policies. So claiming ignorance is not a valid excuse for violation. Furthermore, things like participant re-identification and most information disclosures are disallowed, as of conducting research that is potentially stigmatizing to individuals, families, groups, and communities. On this last point, we encourage users to reach out to the program if they need guidance. And it's a hard topic to wrap your head around. So we have instituted a resource access board that is equipped to assist users in determining how to minimize the potential of their research project to produce or reinforce stigma. And we explain the rules carefully and comprehensively as a component of the training that users must undergo as a condition of their access. Again, claiming ignorance is not an option here. So if a user does violate the terms of use, they're subject to penalties consistent with the scope and the impact of their violation. So I think I'm going to wrap things up here. So I'd like to leave a lot of time for questions, but I would like to leave you with one thought. So next slide, please. Doing a project like this is really, really hard. And in many ways, we have one chance to get everything right. But it's also extremely exciting. Moreover, it's extremely important to do this. We're on the cusp of a project that has the potential to revolutionize the practice of science and furthermore extend the application of that science to meet the needs of a greater and more diverse group of people than ever before. And that is truly remarkable. Next slide, please. And with that, I would love to take your questions.
Great. Thank you, Dr. Brzezinski. So I'm going to open it up for questions, and I'll ask a few here that we have. And if you have any questions you'd like to ask directly, go ahead and click on the question box there at the bottom of your screen. So first off, Dr. Brzezinski, which diseases does the All of Us research program study?
So we are actually disease and condition naive. We take anyone and everyone who wants to sign up as long as they meet the eligibility criteria. We are not focusing on a specific disease or a set of diseases. Yeah, go ahead. Sorry.
And Dr. Brzezinski, how long do you think it'll be before you see results from your study in the form of new ways to prevent and treat diseases?
So I think it depends on the condition. I think that one of the first sort of groups of data that will be made available will be the electronic health record data and the survey data. So we'll be able to use the data to do some of those sort of association type studies between patterns of health over a lifespan and self-reported data, including demographics. I think that there are some limitations of that, but certainly looking for patterns of performance of particular treatment regimens over time in certain populations is something that will be potentially feasible earlier on in the process of releasing that data. So within a number of years, we may see a remarkable increase in the effectiveness of certain treatment regimens targeted for particular patient populations. However, over time, and as the data set grows both in number and in depth, I think the comprehensiveness of the research results and the findings that will associate, for example, genomic data will enable an even greater level of precision. And that won't be possible until that data is produced.
So if ABC members wanted to find materials to share about the program with their constituents, where would they go, or what would they do, or how would they go about doing that?
So hopefully on the screen right now, you will see on the last slide here, we have our website, allofus.nih.gov. We have materials that are available through that site as a good first place to start. Also, one of our community partners is the American Medical Association. And I believe on their website, they are providing additional materials that are geared towards provider populations, but are also relevant to many patient advocacy groups as well about the All of Us research program and the scope. Yeah.
So one of the questions came across here says, can you provide an example of a medically actionable result and how it might be shared with the participant?
That's a very good question. So right now, we are in the process of applying for an IDE to return ACMG 59 variants. So for example, a BRCA1 or a BRCA2 variant could be, you could get a participant with a positive result to BRCA1 or BRCA2 mutation, and we would be returning that to the participant. Any kind of positive ACMG variant, however, will be returned to the participant through a genetic counselor. So what would happen is, in theory, and of course we're not doing this yet because we haven't done any sequencing at this point in time, that the program would reach out to the participant and say, we have your genomic results. We would like to set up an appointment for you with a genetic counselor to receive those results. Once the person responds and an appointment is set up, the genetic counselor will both provide a report to the participant that they may share with their healthcare provider, but also to explain that report and explain what those results mean and answer any questions that the person might have about what those results mean and how to deal with this information.
So we also, so Doc, we got another question. Someone asked whether there are any cognitive components to this study.
In what respect? Are we going to be running any cognitive batteries on folks? At this point in time, not to that level of specificity. There is a mental health campaign is sort of the next batch of data that we'll be releasing. That a component of that will be a self-report form on mental health and substance use. We will also be incorporating aspects of mental health data from electronic health records and cognitive and treatment risk data from electronic health records into the resource, and that includes any kind of medical imagery. So there may be at some point MRI available. There's also the potential at some point in the study for researchers to recontact a subcohort of all of us participants and run additional tests. So for example, if someone did want to run a more targeted study on a smaller group of people, that would include like cognitive batteries or scanning and imaging. That would be possible, potentially, depending on approval. And then that data would be uploaded and integrated into the resource and available then more broadly.
Okay, excellent. So another question came in. It says, so the overachieving theme is the goal is to be a clearinghouse of information for other researchers to use data collected so they can formulate their own specific research for a cure for a particular disease. And is it just a big, it's a big data bank, correct?
Data and actually also samples. So part of the collection of samples is to provide sequence data through the program itself, but also like with participant recontact, there is a potential for researchers to contact the program and request to use portions of those different types of samples for their own research end. Those proposals would be approved in advance. So unlike the data passport, both participant recontact and biosample access would require IRB review potentially, and also approval by the program of that research proposal. And then, again, we could produce almost any kind of data with that. So.
And another question was asked about, what about brain injury data?
Is there a specific modality of brain injury data that you're interested in?
Yeah, they
didn't specify?
They didn't specify.
Okay.
Yeah,
again,
oh, here we go. MDDS?
I am not familiar with that, and I'm unaware of that specific modality of data, but if you wouldn't mind emailing me, my email is also on this slide that should be on your screen right now with your specific question, and I will make sure to route it to the appropriate person in the program and get you an answer.
Yeah, she mentioned it's called disembarkment syndrome. So.
Yeah, I mean, again, we're restricted a little bit to the types of data that we're bringing into the program, but yeah, please contact me offline and I'll make sure that we get you some sort of answer that at least satisfies your curiosity.
Yeah. Another question, can anyone join the study? And for instance, will the program accept children?
At this point in time, we are not enrolling children. However, that is something we hope to be able to do by the end of either this year or next year. So it's our next round of expansion in terms of our participant population. As I'm sure many of you are aware, enrolling children is another set of conundrums that we need to face. And there are relevant state level laws and regs that we need to follow in order to do that appropriately. So we're working our way through that right now, but it's just going to take us a little more time.
And unless anyone else has any other questions, I got one more. So I think you covered some of this in your presentation, but what would be expected of people when they join the program, individuals?
What would be expected? So we have a set of 3 basic survey modules that are part of the core survey data that we're collecting. There is also, obviously, the process of consent. We are asking for people to fill out both the primary consent that goes over the core participation expectations of the program. And most people, as long as they're living in a state where there is a healthcare provider organization, are presented with the HIPAA authorization. For folks who are not living in a state with one of those healthcare provider organizations in their state, they are given an attestation and asked whether they would be interested in, at a future date, donating their electronic health records. After that, they are again presented with those survey modules, and some of them, depending on the information that they share and depending on certain things like demographics, again, we're trying to oversample from certain populations, people will be selected to come in and to provide specimens, and those specimens will then be used to generate whole genome sequence data, as well as parts of those specimens to be reserved for additional studies. But that's the limit of expectations at the present time. We will be, over time, again, releasing additional opportunities to engage with the program and to continue participation. Some of those will include, for example, in states where there's a term of sorry, I'm forgetting the word I'm trying to find here, but when there's a limit on the amount of time we're allowed to collect EHRs, we will be asking people to sign another HIPAA authorization form. There will be additional data that we'd like to collect. So, for example, some people will be invited to participate in donating their Fitbit data. If they already have a Fitbit data, if they already have a Fitbit, they can actually already do that. But in some cases, we may be giving people Fitbits in order to provide that data. And then there will be additional surveys over time. We have SNAP questions, and we're hoping that people will then engage with the program over time by receiving their results back and being able to track how their medical care changes over time after they receive those results.
Okay, great. Another question came in and said, are there samples of the surveys available so people can see the questions prior to consenting?
So my understanding, although I have not checked today, and we are having some issues with our website, but is that those surveys are in their entirety posted on our website. So they should be available publicly.
Okay, so you can see them before you have to answer them.
No, they should be able to see them before they have to. Anyone can see them right now. You can go to the website, you don't sign up for the program, you can just read through the survey. And moreover, people don't have to answer any question they don't want to. If you don't feel comfortable answering a question, you don't have to answer it. It's not a requirement.
Okay, well, I think that's all of the questions that we have, unless someone's got one last minute here before we wrap this up. If anyone has any questions, go ahead and type them in the box. I think we've answered everything, Katie, so I think we're probably ready to wrap this up. So just so everyone knows, the webinar was recorded and will be available on the ABC's website. And want to say a special thank you to our speaker today, to Dr. Catherine Blazinski, who again is the Policy Director for the All of Us Research Program. And thank you to all of you for participating. The ABC's Program Committee welcomes your input as we brainstorm for future webinars. So please contact Katie or Sheila with any ideas, or me, you might have for future programs. And again, thank you guys for joining us today. Again, thank you, Dr. Blazinski, and everybody have a great day.
My pleasure. Thank you.